This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. And if you're a regular, welcome back. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. And we have been coming to you since 2016. This is our 10-year anniversary. And I'm going to say it all year long because I can't believe we made it this far. And we give you continuing medical education on everything related to pediatric hospital medicine. And normally these are topics that either in the content specifications or interesting things that have come up. And this is no exception. Now, we are in our 7-part vaccine preventable illness series. So let's get this straight. There's no way I could have done this alone. So we have partnered with the Pediatric Infectious Disease Division here at UPMC Children's Hospital of Pittsburgh. They have been kind enough to lend their expertise and their time to help walk us through these vaccine preventable illnesses. And the reason we need to do this clearly is things are changing. CDC has updated their guidelines. That's making people rethink this. So we as clinicians need, and those who take care of children, need to be fully up to date on all of the issues related to these vaccine preventable illnesses, both before and after the vaccine, in order to answer any questions and help guide people towards the right choice for them, which for overwhelmingly is vaccinating. So today's episode is on Haemophilus Influenzae B and Pneumococcus. So we have two, for the first time in this series, friends of the podcast back on the show. And one, you know her, you love her, you remember her for teaching you biostats. Dr. Philana Lin is back. She's an associate professor at UPMC Children's Hospital of Pittsburgh in the Division of Pediatric Infectious Diseases. She's a master's in clinical research from the University of Pittsburgh. She wears several hats. She's an accomplished physician scientist with expertise in the host pathogen interaction with Mycobacterium tuberculosis and TB HIV co-infection. She's the site PI of a nationwide multi-centered pediatric study group examining the serotype changes of invasive pneumococcal disease before and after universal pneumococcal conjugate vaccination for the last few decades. This is why we asked her. As the Pediatric Infectious Disease Fellowship Director, she's also deeply committed to the clinical research and academic education of her fellows. And she was recently appointed as the Infectious Disease Division Director right here at Children's Hospital of Pittsburgh. We're going to welcome them both together, but I'm going to read about, and this particular guest hasn't been here in a while. You remember him from 2017, the very first year of our show. We were 3 or 4 months in, and he did the one of our most popular episodes, acute hematogenous osteomyelitis. And then in 2022, we had him back for the adenovirus issues. But Dr. Michael Green, he's a professor of pediatrics, surgery, and clinical and translational science right here at the University of Pittsburgh School of Medicine. He received his medical degree from the University of Illinois in Chicago and his master's degree in public health from the University of Pittsburgh in Pennsylvania. He completed pediatric residency and a fellowship in Peds ID at Children's Hospital of Pittsburgh. Upon completion of his training, he joined the faculty in the department here at the University of Pittsburgh School of Medicine, where he is a professor now. Through his career, Dr. Green's clinical and research interests have focused on the prevention and treatment of infections in immunocompromised children, with a particular focus on children undergoing liver transplant. He also has an interest in antimicrobial resistance and its spread in the pediatric population in the inpatient hospital and the community setting. He served as a director for infection prevention and antimicrobial stewardship here at Children's Hospital of Pittsburgh for many years, and now serves as the associate medical director for both of these. He's an active teacher, a clinical researcher. He's consistently received grant funding for his work since 1987 and has published more than 190 peer-reviewed articles. So friends of the podcast, Drs. Green, Dr. Ling, thank you for joining us.
Hello, thank you.
Yeah, my pleasure to be back, Tony. Thanks for asking us.
So we have to do, because this is a CME podcast, we have to do our disclosures. I will go first. Ling, I'll kick it out to you. Mike, you'll back clean up. So I have nothing to disclose.
I do not either, other than the fact that I'm involved in an investigator-initiated study about invasive pneumococcus that you talked about before.
And I have to acknowledge that I am a consultant for a company called ITB-MED and also for Bristol Myers Squibb. In both those cases, I serve on data safety monitoring boards for those companies relating to impact of immunosuppressive medications on patient populations under study.
Thank you for that. Thank you very much. So, what we've been starting with, everyone kind of knows at this point the national headlines and why we're doing this because we're seeing less and less vaccinations, and I think we're going to see less vaccinations unless hopefully this works and this catches fire. Then these podcasts become just a standard issue for everybody. But if barring that from happening, let's get into let's go back to first year medical school microbiology 101. We're here to talk about Hib and pneumococcus. So can you take us back and just remind us of these organisms? Then we'll talk a bit more about what's going on.
Sure, and I'm happy to go first. So alphabetically, Haemophilus influenza type B is a pleomorphic gram-negative cocobacillus. That means it looks a little bit somewhere between a rod and a cocci when you look at it underneath the microscope. Microbiologically, it's unique in that it requires two factors, NAD and heme, in order to grow. And this is why it only grows on the chocolate plates. And it's one of the most important reasons in pediatrics why specimens, particularly respiratory specimens, but also blood and spinal fluid, go onto chocolate plates as well as blood agar plates. It grows pretty well when you follow those rules. It doesn't grow on plain blood agar plates. It doesn't grow on the selective gram-negative plates. And historically, it was a very important pathogen, and we'll talk more about that later.
So I'll talk about Streptococcus pneumoniae, which is not a gram-negative, but a gram-positive organism. And if you remember way back in first year medical school, its morphology is gram-positive cocci in pairs and in chains. Both of these organisms are known to be encapsulated. So when we talk about patients without a spleen and who are susceptible to encapsulated organisms, they are susceptible to pneumococcus. And unlike Haemophilus influenzae, there are a handful of different types of Haemophilus influenza. Haemophilus influenza type B is the most popular and dangerous one. With pneumococcus, there are 90 different serotypes, and that's why you'll see the conjugate vaccines come out in series where it covers 7 of the most common serotypes that cause invasive disease, and then 13, and now we're up to PCV20 and 21, and it's because of the complication of having 90 different serotypes, and each serotype has its own sort of behavior. The other thing that I think is unique about pneumococcus is it is normal flora in your mouth, normal flora in your nose, normal flora elsewhere. So we always run into the problem of culturing something that we may not necessarily need to treat. So just to recognize that we get nervous about finding Hib or Haemophilus influenza type B anywhere. Sometimes we're not so nervous about finding pneumococcus. It just depends on where you happen to find the organism.
That was a wonderful recap. Now, I'm going to tell our listeners I've been most concerned about Haemophilus influenza B. Well, as we've seen the vaccination rates go down, there's actually just a national headline talking about the concerns of vaccine preventable illnesses coming back. And there was something like the potential of Hib come back as vaccination rates decline. I remember when I was training, the professors who trained me in Newark, New Jersey, was UMDNJ, New Jersey Medical School, talking about before the Hib vaccine, how much meningitis they saw, how many kids they would tap, and how it's so much different now. And thinking that may come back has been unnerving. So what I want to start with, and Mike, I'll kick this out to you. What do you think was the greatest impact of the introduction of effective vaccines against Hib? And you can even add pneumococcus, but we'll get Ling's impression on that. But Hib specifically.
So I want to start off by saying, Tony, I would be one of those instructors that you had in Newark. When I came to the Children's Hospital of Pittsburgh for residency in 1983, we had no vaccine. And to give you an idea, locally, we had 50 cases of Haemophilus influenza type B meningitis every year. And that was year in and year out, and it wasn't particularly seasonal, so you were always on alert. And Haemophilus influenza type B did not only cause meningitis, but it caused a variety of other bacteremic syndromes. You could see a kind of cellulitis that was called buccal cellulitis involving the cheek, or you could see periorbital cellulitis, and you could see Haemophilus was also a relatively common cause of musculoskeletal infection in the first few years of life. So this was really common, and we saw it every year. And then there were other syndromes, such as epiglottitis, that we saw as kids got older. This was not a bacteremic syndrome, but it was actually quite life-threatening and really very scary. And to take you back in time, if you were in the emergency room in the years before there was the vaccine, and a child who was 6 years old came in, and there was concern for how they were positioning themselves, maybe leaning forward, maybe think peritonsillar abscess or retropharyngeal abscess. We actually were instructed, don't go in the room, stand at the door, ask a few questions, and then wait for the anesthesiologist and ear, nose, and throat attendings to come in to take the child to the OR to intubate the kid, because this was a life-threatening or at least CNS-threatening event, because if the airway was obscured or blocked, then they would get anoxic and they could suffer injury. So those days, very, very common. We saw it all the time. We did lumbar punctures all the time. I mean, this was really very, very common. And we didn't have interventional radiology back then, but we had a lot of practice. And more importantly, the nurses had a lot of practice. They were great holders, and it really allowed us to get this information. So you're really looking at a time where this was really common. And I gave you sort of local data. If you go to national data, it was thought to be, before the vaccine was available, thousands and thousands of cases nationwide, with a rate of around 3 per 100,000 for evasive Haemophilus influenza type B. And just to foreshadow the impact of the vaccine, 2 steps. First, a polysaccharide vaccine. But the problem with the Hib polysaccharide vaccine is that the disease was seen in children less than 2, and the polysaccharide vaccine didn't work in children less than 2. And it really led to the invention and then implementation of the conjugate vaccines. And after its introduction, more recent rates in the last several years suggest that the rate is at 0.03 per 100,000. So from 3 per 100,000 to 0.03. And it's why we rarely see cases of invasive hip disease now. And clearly we only see it with any likelihood in the unvaccinated or undervaccinated population. So a dramatic difference in what we see. And our current trainees don't really know much about Hib, but the trainees from when I was a resident lived and breathed Haemophilus influenza type B as a pathogen of concern every day.
That was a fantastic recap, and 100-fold decrease for the vaccine in terms of incidence is an amazing thing. So, Ling, how about I ask you the same question about pneumococcus?
So I don't want to date myself, but I did do residency after Dr. Green. And during that time, which was the late 90s, we rarely saw Hib because the vaccine was like a huge success. But what we worried about the most was pneumococcus. And so pneumococcus has a lot of different faces, right? It's the number one cause of bacteremia. It's a common cause of meningitis. And in fact, was the most common cause of bacterial meningitis now that Hib was gone, was a common cause of community-acquired pneumonia, especially complicated community-acquired pneumonia, and would also cause occasionally musculoskeletal infections. So like an osteomyelitis or a pyomyositis. But the biggest problem and worry that we had at the time was really identifying the kids who had what we call the cult bacteremia. Those are kids who came in basically with fever and no other source, and you weren't quite sure if they were bacteremic with pneumococcus and would come back with meningitis, or if they were fine and they just had a virus. So we didn't have these rapid viral tests, assays that are available today. God, I feel old. But that was the biggest worry, right? Especially in the emergency room. When you're on rotation in the emergency room and you get a baby who comes in with fever, or a toddler who comes in with fever, you didn't necessarily know if they were going to be bacteremic at the time. And I had this horrible experience as a resident where I saw a kid the day before with fever that got evaluated. We did the workup and then came back a few days later and seizing with pneumococcal meningitis. Those memories they don't go away. And they remind you of the great success that vaccines have had, because I'm not sure our residents will ever have to see that, hopefully, again. It still happens. It just doesn't happen very often. And it's had a huge impact on what we do and how we manage fever. I will say that with pneumococcus, the epidemiology is a little bit different. So what Dr. Green was describing was this sort of bimodal distribution where you saw a lot of disease in the infants and you saw a lot of disease as toddlers. For pneumococcus, you see a lot of disease in those less than 5 years of age, and then you see another. It declines by a lot. And then you see the other risk factor group, which is after 65. And so if you watch television, they'll talk about the pneumonia vaccine for the elderly. That is the polysaccharide pneumococcal vaccine. And now since the success of the conjugate vaccine, the over 65, actually, I think it goes up to 50 now, is a conjugate vaccine plus the polysaccharide. But in infants, it's the same story that parallels, right? We had the polysaccharide vaccine. It didn't work very well because it was really for children who were over the age of 2. It still didn't work very well. And then when the conjugate vaccine with Hib became a success, then they rolled that into pneumococcus, and it was a huge success. And decreased our rates tremendously. So they, in many ways, parallel each other. They are both bad diseases in the very young. We tried to prevent them with polysaccharide vaccines. We didn't do a very good job. And then we did amazingly well with conjugate vaccines.
That is fantastic. I mean, this is I'm learning so much. So now, Mike, we've kind of gone through the general epidemiology of Haemophilus influenza B. Is there anything else you wanted to bring up with that? Or are you comfortable with what we went over?
So thanks for asking me that question, because there is something different about Hib that I want to point out. And that is that there was a relatively high risk for secondary cases of invasive Haemophilus influenza type B in both the household and in the daycare setting. And this was because of the presence of colonization with Haemophilus influenza type B in the nasopharynx. And when we finished treatment of a child with invasive disease, they were still colonized, and we had to give them secondary prophylaxis to eradicate colonization. And we identified members of their household or daycares that they participated at where they were also at risk. And this is another sort of miracle of the conjugate vaccines, because they not only provided protection to the children who got vaccinated against invasive disease, but also protected against the establishment of colonization. So you really got the truest sense of herd immunity in those that received the Hib vaccine, because they not only didn't get sick, but they didn't get colonized, and therefore they couldn't spread it to others.
And I would just jump off on that, because the same thing actually happened with pneumococcus. Soon after the pneumococcal conjugate vaccine, the PCV7, they noticed even within the first year of its rollout. So when the PCV7 came out in 2000, there wasn't actually enough to go about universally. So it was only about 40% compliance in the first couple of years. And yet they saw a dramatic decline in the number of invasive pneumococcal disease cases, and they saw a huge reduction in those who were 65 years of age and older. So the sort of same thing applies. It reduced colonization of those serotypes that caused invasive disease, and it reduced the spread so much that, in fact, it reduced the incidence in the elderly who were not directly getting the vaccine. So both the direct and indirect effects of the pneumococcal conjugate vaccine were immense and also contributed to the herd immunity. So it's a pretty phenomenal experience to have lived in those eras and been able to see the dramatic reduction.
I gotta assume, and I don't have the data to back this up, but that daycare specifically from the 1970s to the early 80s, the amount of daycare usage in the US has gone up exponentially. And so I would assume if we go backwards in terms of herd immunity and people getting Hib, there's going to be a huge issue with what you're talking about with secondary prophylaxis and well, what you just brought up, Mike. Would you say that's fair?
Yeah, I think that's true. And you have to also understand it wasn't only the pediatricians in the community or at the hospital who were dealing with this, but this really involved the public health service. So your county health departments or your state health departments had to get involved as well, because it was no small feat to provide prophylaxis to a daycare of 35 children, which we sometimes did. We would go out as members of our division and we'd go to a daycare. We actually could do culturing. We had a selective media that identified the presence of Hib colonization. So we were collecting data, but we would provide that prophylaxis to families, to the children that were in the daycare. And so the risk would be real. I think you're correct that it would be exaggerated compared to the amount of daycare that was present then, and the rates could really be phenomenally high.
It's amazing. All right. So I have next, if we had a case, let's go back in time to the pre-vaccination era. If we had a 4-month-old, otherwise unremarkable birth history, fictitious patient, so just so we're clear, because this is HIPAA, we're not going to use real patients. We are going to use fictitious patients. 4-month-old, otherwise unremarkable birth history, who came in with fever, poor feeding, and lethargy, which is still a very common presentation nowadays. If I were in the pre-vaccination era, what am I looking for, Mike?
Well, you're looking for a sick child, and recognizing that a 4-month-old is challenging because they don't always tell you that they're sick and they don't localize their infection. So the presence of risk for invasive meningitis, either for Haemophilus influenza type B and less frequently back in the day, Streptococcus pneumoniae, was high enough that we really did a lot of spinal taps. We did complete sepsis workups in these baby because the risk was high and the exam was not always to be trusted. So it's easy to decide to tap an irritable baby, but it's harder to decide to not tap a highly febrile child who's a little bit punky with their fever, who doesn't have the protective benefit of these immunizations when those rates are high enough. And again, I told you earlier, we saw cases of Haemophilus influenza type B on a nearly weekly basis, and sometimes more than once in a week. And so this was high on our list. And so these children got full workups and frequently were admitted and put on antibiotics while we waited to see the results of those cultures. So it was really very impactful and much more concern than I think today, where we still worry about the 4-month-old, but now we're more worried about, do they have a UTI that we're not able to see? And less frequently do we see meningitis. We see residents all the time on our ID service or even our first-year fellows, and we ask them, how many cases of bacterial meningitis did you see in your residency? And they'll say, one, maybe two. And of course, we saw literally each more than dozens of cases each year because of that prevalence.
Yeah, I will tell our listeners, even from when I started training, it was any baby that came in under 90 days old got a tap. And then throughout my training and in my early attendingship, it became any baby under 60 days of life got a spinal tap, a lumbar puncture. And now it depends from 0 to 21 days, 22 to 26 days, and 27 days to 60, or 29 days to 60. It depends on certain factors in the lab work and the presentation. And when you look at the AAP guidelines on that, the thing that they always start with is because of the success of Haemophilus influenza B vaccination and Group B strep treatment of pregnant women during their labor, the rates of meningitis in infants have gone down significantly. So what we're talking about, we're not talking about a huge time. I may look old, but I am actually quite in my 40s. So I'm not as old as I look. All right. So we talked about this. So now you mentioned bimodal distribution of Hib. What are some other important invasive diseases caused by Hib in children?
Well, I think I mentioned these, but I will mention them again just to make sure the audience can hear it. So there's meningitis, which certainly got the most attention and deservedly so. And then again, if you're looking at the younger child, a child less than 3 years of age, but particularly in the first 1 to 2 years of life, we saw bacteremic consequences of Haemophilus influenza type B. So we could see the cellulitis, the buccal and periorbital cellulitis that I mentioned about. We could see septic arthritis or osteomyelitis due to Haemophilus influenza type B. We also knew that there were cases of pneumonia, but we didn't always prove those cases. We see it clinically, a positive X-ray and a positive blood culture. And then as they got older, the epiglottitis, which we did not see in the little babies, we really saw that in like the 5 to 8 age group. I will say, although it's less common than pneumococcus, if you look at the old data, the elderly also had a rate of invasive Haemophilus influenza type B, but not nearly as important a problem as strep pneumoniae. And the one other point I want to make is that in part, we think that you didn't see Haemophilus influenza type B as you got older because it was thought that you developed immunity from cross-reacting enteric flora in our GI tract, which gave us the protection against invasive Haemophilus disease, although it did not impact at all colonization rates in the nasopharynx. So there would be people who could be protected, but who could carry it and could pass it on. And when I talked about doing prophylaxis against secondary cases, that included prophylaxing or treating the elder siblings and the parents because they could be colonized and a source of disease going back into the child that had infection because you didn't develop immunity until you were 2 years of age. So if you were a 1-year-old and you got Hib meningitis and we treated you, not only could you still be colonized, and we dealt with that by giving you an antibiotic, usually rifampin at the end of therapy, and then subtractin was found to eradicate that colonization, but you could get reinfected by the concept that's in the house. And so we had to give the parents also medication, usually rifampin. And so that was a real big part of our management and something that we worried about.
Okay. Now, Mike, we've talked a little bit about what happened after the vaccine. I don't know if you wanted to bring up about high-risk populations at all, how that affected them.
Well, yeah, thanks for bringing that up to me and reminding me, Tony. So we know that there were certain populations that were at particular risk for invasive Haemophilus influenza disease. And the populations that we thought about were obviously those with issues with their spleen. So the sickle cell population and other children without asplenia or with asplenia, who, of course, are at risk for encapsulated organisms causing invasive disease. But there was also an identified risk in children that were Native American and as well as Eskimo. And it was actually interesting, and Ling and I were talking in advance of getting together on the podcast of how for a while you get vaccine type 1 as your first dose because it got you protection more quickly, but then subsequent doses with vaccine type 2 because they provided a more persistent and enduring level of protection. And so we had knowledge of these risk groups and we treated them differently in terms of vaccine approach to try to mitigate and minimize their risk. But all that concern again went away with the success of this vaccine and the eradication of really colonization. The disease just really nearly disappeared. A miracle and truly amazing.
And have we talked about the fatality rates? You brought up 3 cases per 100,000 in terms of incidence, dropping to 0.03 per 100,000 post-vaccination. Have we talked about what the mortality rates were?
So, Squibb was an organism which, while it caused invasive disease, did not commonly cause death. Of the causes of bacterial meningitis, about 25% would get some level of hearing loss, either unilateral or bilateral, mild, moderate, or severe hearing loss. But it did not typically kill you. And the epiglottitis patients were at risk because their airway could be embarrassed, and you might not be able to get a tube in, and they could end up getting tracheostomy. But death was relatively uncommon. Morbidity was relatively common.
Okay, so 25% of those patients who would get meningitis would have either unilateral or bilateral hearing loss. And then, of course, with epiglottitis, there was the risk of tracheostomy having to be placed, but death was uncommon. Is that right?
Right. And you could also have neurologic sequelae from epiglottitis because obviously if your airway is not able to allow oxygen into the lungs, you are going to get ischemia and injury from that.
Okay, and that can lead to hypoxic ischemic encephalopathy, developmental delays. Perfect. That's a very nice recap. Now, Ling, I'm going to pick up with you. So now, moving through history, in the late 90s, we saw that we had the benefits of the HIV vaccine. So you weren't seeing a lot of that in training. You talked a little bit about strep pneumoniae and how its historic vaccination process went. But what was the general epidemiology of pneumococcus prior to the conjugate vaccine? You want to recap that with us, please?
I think when most worrisome part was in the high risk group, right? So those are the kids who are less than 5 years of age, and especially in the kids who are less than 2 years of age. And probably the number one clinical scenario you ran into was exactly what you talked about, right? So let's say you have a 2-month-old kid or near 3 months, because I think I had the sort of the same training as you. We did almost a full rule out sepsis workout for any kid less than 3 months of age at the time, because you just weren't sure who was going to show up with occult bacteremia and meningitis, and perhaps you might miss it. But I think this is where, and this is going to age me completely, right? This is when things like the Rochester criteria came into place, right? Could you identify who was which neonate was at low risk for serious bacterial infection? And then Philly had their own version, Pittsburgh had their own version, but basically your role was to try to figure out who was at lowest risk. And I assume that the residents still talk about this now, like being full term, having no significant past medical history, no prior hospitalizations, had no perinatal antibiotics that could mask a syndrome, for example, no antibiotics in the last 7 days, no sibling who had group B strep, and actually was a well-appearing child to an experienced provider being important, having no focal infection except for acute otitis media. And then you had to do the lab work, right? So if you had a white count between 5 and 15,000, the band count had to be less than or equal to 1,500. Your urinalysis, no pyuria. At Pittsburgh, we had an enhanced urinalysis with no pyuria, a lumbar puncture of less than 5 with a negative gram stain, plus or minus chest X-ray if you had respiratory symptoms or white cells in the stool if you had any diarrhea. Like those were sort of the criteria for which you could say who had low risk that you might be able to send home or consider just watching on no antibiotics. And then there were subsequent studies after that said, well, the 28-day-olds or less, sometimes you were wrong. And so you couldn't really apply those criteria. And so then it was basically every 28-day infant can potentially lie to you. And so we did everything, and we started empiric antibiotics, and we watched over the next 48 hours on empiric antibiotics. And then you could choose what you wanted to do between the 1 month and 3-month-old. But that age group was still a tough age group. And I can remember my attending saying, well, back in my day, we had to tap like the 6-month-old kid, which just seemed like heresy. But at the time, without HIV vaccination, that was real. Mm-hmm. And then I would say that, in the older age groups, the main manifestations were things like, oh, wait, let me go back. Let me go back and talk about like the bacteremias and the meningitis. The problem with pneumococcus is that there are 90 different types, right? In that age group of less than 2 years of age, it was dominated, 80% of those cases were dominated by 7, which is how we got the PCV7. And those serotypes were responsible for penicillin resistance, were responsible for what we call non-susceptibility to cephalosporin. So cephalosporins could have been intermediate or resistant. That was a major problem. And the kids who were at risk are the ones who went to daycare, for example, or who had previously seen antibiotics. So it was really bad. You have a kid who's diagnosed with meningitis. You don't know if you're on the right antibiotics. And there was a debate at the time. I read these old papers that talked about ceftriaxone, which was new at the time, and then the use of vancomycin, or, get this, and I've never had to prescribe it, chloramphenicol.
Oh, gosh.
Yeah, so that's the era where we had to really worry about penicillin resistance and cephalosporin resistance. So not only did you want to reduce with the vaccine the incidence of bacterium and meningitis, but you also wanted to get rid of the risk of penicillin resistance and cephalosporin resistance, or at least that was the idea. And with both the Hib vaccine and with the pneumococcal vaccine, the worry was, okay, if we got rid of Hib, would the other types come up? And the same thing was true for pneumococcus. If we got rid of those 7, would other non-vaccine serotypes come up? And actually, we did see that. And that's sort of how we evolved in the PCV13 and the PCV20 and the PCV21. Overall, the incidence fell dramatically, but there is still sort of a replacement. People talk about serotype replacement all the time. But the truth of the matter is that when we rolled out PCV7, we not only saw a dramatic decrease in the incidence of bacteremia in those less than 2, decreased incidence in meningitis. Meningitis, by the way, still has the mortality of like 7%. Still has significant, I think, more than just slightly over a quarter of those patients have significant developmental delay. Similarly have deafness. So it's not a trivial diagnosis. So we saw a huge reduction in meningitis, saw a huge reduction in bacteremia, actually saw a reduction in pneumonia in children, and also saw a reduction in acute otitis media. Not huge, because remember, people keep saying, oh, it was a failure. It wasn't. It was not geared or targeted towards otitis media or pneumonia. It was targeted against the most invasive serotypes, which were the ones that caused bacteremia and meningitis. And I think that's still an important take-home message, because right now when we message parents about vaccines, we need to be very clear about what we're trying to protect against, because we happen to live in a lap of luxury of saying, oh, this won't happen. It might happen. It just might not be as severe as it would have been without the vaccine. But there's no question that was a huge reduction. But it is still an important pathogen when it comes to community-acquired pneumonia, acute otitis media, the complications of acute otitis media. We still see it with osteomyelitis and other musculoskeletal infections. But it had a huge impact on the way we practice medicine for the babies, no question about it. And it had a huge impact on susceptibility. But we still do vancomycin and cefotaxime, ceftriaxone, or cefepime, depending on what you have in your hospital. But the vanco is really for the resistance. And to this day, we still have about a 10% rate of penicillin resistance or non-susceptibility to cephalosporins, which is why you still need the vancomycin when you are doing empiric therapy for meningitis.
Yeah, I was just going to feed off of Ling's comments about how we chose our antibiotics to target the germs that we were worried about. And I just want to revisit the fact that if Haemophilus influenza type B resurgence occurs, and you see a 2-year-old in the emergency department or on the floor, and they have osteomyelitis or septic arthritis, cefazolin really has become our backbone drug, because we're really worried about covering Staph aureus and, to a lesser extent, Streptococcus pneumonia, and actually also Kingella in that age group. But Haemophilus influenza type B was in the top 2 or 3 causes in the toddler in the days of Hib, and you couldn't use cefazolin because it's not active. And so, again, sort of rethinking choices that you would use for your antibiotics if you now have to cover Staph aureus and Haemophilus, you get to like a second generation cephalosporin like cefuroxime, which was used a lot and was really a major breakthrough. But we also now have like ampicillin sulbactam, which would cover both Staph aureus and Haemophilus influenza type B. But if these germs come back, or if HIT comes back, it really makes us rethink our empiric antibiotic in age groups that are at risk.
That's a great point. Lynn, can you give us some numbers for the incidence changes pre and post vaccine of pneumococcus?
So in the US in 1998, I'm trying to think of like the music back then, the incidence of invasive pneumococcal disease is estimated at 97 cases per 100,000 in kids less than 5. And then about 60 in those per 100,000 in 65 years of age or older. So just with PCV7, so back in 2003, which is where the big paper was, that incidence fell from 96.7 per 100,000 to 23 per 100,000 in the 5-year-olds. And then in the 65-year-olds, now remember, those are adults who were not directly vaccinated, right? So they had the indirect benefits. It went from 60 to 40 per 100,000.
Wow.
So that's pretty impressive. And it's even better now. I don't have those statistics with me, but it's even better. Well, I shouldn't say even better. What happened is you saw this dramatic decline. And then what's left has been fairly stable. And so that's been the biggest thing that we've been studying so far is, I would say every 5 to 7 years, we take a look at the invasive cases across 8 independent children's hospitals. And it turns out that I would say about 25 to 30% of the cases of invasive disease in children are from those vaccine serotypes. Often they are from children who have not yet had the full primary series. And then the majority are from non-vaccinated serotypes, and they are more often than not from immune-compromised hosts. But it has actually changed our practice, right, universally to say that if you have a child who has pneumococcus from a vaccine serotype, that at least should warrant a workup for your immune workup, because something like 20 to 30% of those kids actually had an immune deficiency that was otherwise not going to be recognized. And so we've changed our practice quite a bit. One could argue what's the cost effectiveness of doing that if it's only 20%, but I think that's actually a huge margin that you could catch after a single episode. So I think those things are kind of important. They've had a huge impact on the way we practice right now.
Yeah, I mean, the whole way we look at a sick child, febrile sick child, if these vaccination rates really significantly decline, like Mike was saying and like you're saying, would really have to change again to back to what it was, because these diseases will come back.
Yeah, and sometimes it's funny because when we have fresh new interns that do a rule-out workup on a baby, or even let's say like a 6-week-old, I remember the day when we could just watch, not start antibiotics, and watch the kid. And I think that these days it would make people too nervous, but we certainly did that as a resident. I don't know if you did that as a resident, Tony or Mike.
Yeah, we would.
So I guess the question then is, we do see unimmunized children who may or may not come from a community that believes in immunization or not. So there's no question that we see Amish in our patient population. And Mike, as the most senior person, I guess I might ask you, if you got a call from the emergency room for a 6-week-old with fever and lethargy, who's Amish, who's obviously not old enough to vaccinate, but comes from a non-vaccinated community, does that change your practice or empiric therapy?
Yes. And what I would say is that in a 6-week-old, I would not be just thinking about group B strep and say E. coli. I'd go beyond the newborn screen. I would not be using ampicillin and gentamicin in that population, because there was a substantial incidence of beta-lactamase production in HIB, so ampicillin wouldn't work, and gentamicin is not really active. And so you would be considering in that age group, you'd probably be using ampicillin and ceftriaxone, because they're old enough to get ceftriaxone. But then you throw into the kicker that it's possible that what they have is fever from a urinary tract infection. And oh, by the way, the frequency of extended spectrum beta-lactamase production in the community in UTI isolates of previously healthy kids is on the rise. And now you really get it confused, and you have to cover now Haemophilus and the pneumococcus and group B strep, and then maybe resistant E. coli. And you start really having to be using much broader because of this. And that could be concerning because the more we use the much broader agents, the less they'll be around for when we need them in the future. So it's a bad thing.
I mean, I think the nice thing is that we do have herd immunity. So after vaccination, at least it reduced nasopharyngeal colonization. But I don't know how long it takes, right, for a community to stop vaccinating and then for it to take over again.
Yeah, we don't know that, but the good news we do know is that if that community changed its mind and implemented vaccine, the turnaround times when you look at the curves from our experience in 2000 was, or actually 1990 rather, not 2000, was rapid. A really rapid impact. And so we don't know how long it would take to lose these benefits, but we do know that if we were to return to their use, or just keep using them, that we could regain that protection. And if we keep using it, I think there's no evidence to suggest we won't maintain that protection. And one thing to point out here is that, I don't think these vaccines, that is the conjugate bacterial vaccines, really aren't associated with much in the way of signal for adverse events. They're not very controversial. They aren't really associated with even unexpected, call them rare events. They really are exceptionally safe. They really are a miracle.
Now, we have talked about a lot. We've gone through the pre-vaccination area for both Hib and pneumococcal. And if there are any parents, Congress people, who knows, listening to this show, at the very least, these two vaccines we really need to keep going. I mean, all of them we need, but we really don't want to go back in time to the pre-Hib era. I think that would be catastrophic for our children in the country. But Mike and Ling, and I'll start with you, Mike, and then kick it out to you, Ling. Is there anything we didn't talk about that you wanted to make sure we did talk about for these two infections?
I think we've pretty much covered, to reiterate, 20,000 cases a year of invasive Haemophilus influenza type B, 50 cases of bacterial meningitis every year at the Children's Hospital of Pittsburgh, a case in the hospital almost every week, sometimes two. These were just really common and both life-threatening, although thankfully with Hib, they didn't succumb very often, but also with morbidity. And it's just very preventable, very safe, and really, we don't want to go back. Thanks.
Yeah, I would say the same about pneumococcus in the sense that we really have seen a dramatic reduction in invasive disease in children, especially the young children. But it still is a very common cause of acute otitis media, of pneumonia, of mastoiditis. We still see invasive disease, and we just need to stay on top of it. But my worry is that, I don't know that young parents these days have heard of cases of meningitis when they happen, other than in the teenagers who go to college, for example, right? But I would argue that their grandparents perhaps recognized meningitis happening in much broader age groups, and especially in the very young. And it's a devastating experience to have a very young child who has so much potential get meningitis and not be able to predict what their future is going to look like. And these diseases are entirely preventable. And as Mike pointed out, the adverse effects of the vaccines are really quite minimal. So the risk-benefit ratio in my mind is not even a question. And so I hope that young parents continue to try to protect their kids in at least the best way that modern medicine has afforded these days. But I do want to make sure that residents and trainees who have not seen this disease learn about it, because there's a chance that it could come back. And I would say that you should always, it never hurts to talk to more senior people who have had different experiences. The biological pathogenesis of why we prophylax that Mike talked about before, it's not in the Red Book. You have to think about the biology of the bug and how it acts to sort of try to understand who gets prophylaxis, why sometimes we would change practice, right? That's the very basics of understanding a pathogen, which is what we do in infectious disease, understanding the transmission, the disease, how it invades, and how it acts. Always go to your seniors who have more experience, because they can provide a ton of information and helpful clinical pearls. I think we all wish that these diseases would go away and we'd love it, but I think there's a threat right now that they're going to come back.
And one last point to make is if the patient you're caring for is found to have one of these diseases, as Ling mentioned earlier, think about, is that a reason to evaluate them for an underlying immune deficiency? And certainly if they have a history of having received vaccine and they break through, that is something we would highly recommend.
So I guess the lesson is always talk to your ID friends.
I love that plug. I do love that plug. For those of you listening, healthcare professionals, I hope this was helpful. I hope this kind of refreshed things you may have learned at one point on Haemophilus influenza B and pneumococcus. But I really enjoyed this, and I think this was a great, great talk. Ling, Mike, thank you so much for coming on.
You're welcome. It's fun.
Thanks for having us. I enjoyed doing it. Thanks.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.